Canine. Oh, okay. Um, Canine diabetes, in a big kind of multi-institutional study they found was about 1% of dogs that are presented to referral practices, or about 0.3% of dogs that are presented to a primary care practice. So it's fairly common. They actually did a kind of interesting study seeing that cats have been increasing in the prevalence of cats presenting with diabetes to teaching hospitals compared to 1970 versus 1999. And I think there's probably a couple of factors. Are we diagnosing these cats better? I think now more cats are house cats, so we're catching things sooner, but also maybe they are a little bit more obese. And then there's also a fun fact that Burmese cats as a breed have a breed predisposition to diabetes mellitus. They have a hard time managing fat and glucose stores, so it actually leads them to a greater increase of insulin resistance. And 10% of Burmese cats, this is a Burmese cat, greater than 8 years old will have diabetes.
Dr. Lonk, we're not able to see your screen.
Oh
your,
no!
PowerPoint.
Hang on one second. I had a cute cat. There's so many cute cats in this presentation. I don't think I shared my screen properly. Sorry, I haven't zoomed in a long time. There we go.
Perfect.
Okay, so I'll go back and you guys can see the cute cat at least. 1 second. There we go. So I'll move this too. Patients with diabetes have a chronic hyperglycemia, meaning that the blood is high in blood sugar, but the cells themselves are low in sugar. They are glucose starved. So it's actually a disease of starvation when we think about it. It's not a disease of like plenty, even though we think of high blood sugar. On a cell level and on a tissue level, what we're seeing as a result of diabetes is that we're not getting these nutrients where they need to go. So we need to find a way to utilize fat and protein because we can't get glucose. So cells will start to try to compensate for that. And the reason this happens is either due to a lack of response to insulin, which we'll get to that in just a second, or a lack of production of insulin. So either way, the long and the short of it is that we don't have insulin. So therefore, the glucose is circulating out in the bloodstream and the cells are not getting that glucose where they need it to go. Don't mind me, I'm just your dead, starved cells. So when this happens, we literally have a hunger or a starvation mode that starts to happen. And it can be a little bit different depending on whether we're talking about cats or talking about dogs. So dogs in general are what we would consider a type 1 diabetic. The terminology in veterinary medicine doesn't quite match the terminology in human medicine, but I will use the terms type 1 and type 2 diabetes when I'm talking to owners, because most owners are kind of familiar with that. So type 1 diabetes means we don't have enough insulin. So that would be equivalent to like a human with like juvenile diabetes where they're not producing proper amounts of insulin. And that's usually the type of diabetes that we will see in dogs. And that means that dogs, by and large, once we diagnose them with diabetes, are insulin dependent for the rest of their life. They are simply not making enough insulin. And it's usually due to a failure at the level of the pancreas. Now, cats in general tend to be making enough insulin, but their cells are not responding to the insulin. So we call that type 2 diabetes. And that is more similar to what most humans with diabetes are going to have. And that's why people with diabetes, obviously there's a lot of, wellness campaigns with diabetic humans to try to get them to eat better and to watch their sugar and things like that. And that's why a lot of times owners will become very fixated on diet for their pets. And in dogs, it doesn't tend to matter quite as much. But in cats, that does start to play a role in terms of how we can manage their diabetes. So we don't have glucose uptake by the cells, even though there is a lot of insulin floating around. So this is just a little picture for people who are more visual learners like me. So we can have a cell, and cells have little insulin receptors. Can everybody see my little cursor? I'm hearing no complaints.
Yep. Oh yes, we're.
Jimmy, you have to be the voice for the
That's right.
So the cells have little insulin receptors on them. And the insulin binds, it's called a lock and key mechanism. So each insulin receptor has like a perfect fit with the insulin. And then when that happens, it's going to open our glucose channel. So I think of it as we have to have the key in the lock, but then we also have to open the door. And then the glucose can come inside and get to where it needs to go in the cells. So in dogs, we don't have this step. In cats, we have this step and they're binding, but they may not actually fit like that lock and key. So that insulin receptor is not responding to the insulin, and so we're not opening that door. This is like a very complicated picture of what the pancreas is trying to do to make insulin. And just as an FYI, insulin is made at the level of the beta cells within the pancreas. You probably don't really need to know anything crazy beyond that. We think in dogs that this may be an immune-mediated condition. We still don't 100% know. I have seen a few dogs as well that have developed diabetes after severe injury to their pancreas, like a really bad pancreatitis dog. So basically what can happen is those beta cells just sort of either die or they stop making that insulin that we need. And again, that is type 1 in dogs. Insulin resistance or type 2 can happen due to many, many underlying factors. And again, most of your humans are going to be aware of those sort of factors. I think we talked about all of that. This is a scary picture of what happens once the cells take up the insulin. Basically, the long and the short of it is once we get that glucose into the cell, we have a lot of important things that need to happen. And that's kind of what I was trying to illustrate with this picture. We need glucose for a lot of different things. We need glucose for protein synthesis. We need glucose for fat. We need glucose to make more glucose, and we need it for growth and gene expression. So basically, the thing that I want everyone to take away is that diabetes is a disease of cell starvation. Oh, look at that. This is the funniest thing ever. And I'm, of course, as you all know, a giant nerd. So we're going to have a little brief musical interlude because I think that this actually really explains the pathophysiology of how this all works really, really well. Feel free to like get a snack right now.
Katie, this is so sad, but I can't hear the sound. I can see the video.
Yeah, I thought we could hear it for a little bit, and then
There's no music.
You guys can like probably listen to it later. Sorry.
Send us the link later and we'll watch it.
Yes, this is crushing me. We'll come back.
Sorry.
I'm very sorry. I used to show that to my students all the time when I would do rounds because it's adorable. I don't know what that was all about, but now I can't even get my speaker to go away. Sorry, I'm really not very good at technology here, as everyone just learned.
you can probably just click on your presentation. like somewhere on your presentation? There
Nope.
you go. No?
I think I need to, hang on, I'm gonna pause my sharing. No. Zoom, there we go. Oh my God. Ha. Okay, we're back again. Put that thing up there. Okay, so cats with diabetes are a little bit of a different situation than dogs. So it is usually a failure of the beta cells. So we're not responding to the beta cells. And in most cats, they are obese cats. There is a predisposition to males greater than 8 years old. Cats on steroids, that is definitely something we want to warn owners about. I have had cats on very low doses of steroids who probably were kind of right on the edge of becoming diabetic cats that I have now made them truly diabetic cats. I have had cats on AeroCat inhalers that I have made diabetic cats. So it can definitely happen, and it is something we always want to warn owners about whenever we are putting a cat on long-term steroids. And I do usually recommend any cat on long-term steroids, no matter what type, what dose, whatever, is getting their blood work checked, ideally quarterly, minimally like every 6 months to screen for this. And again, I mentioned before, those Burmese cats, they have dysregulated lipid metabolism. So they're always kind of a little bit lipemic. And that is why they are not responding to their insulin very well. Kind of have two classes of diabetes, and which ones you are going to see is kind of dependent on where you're working. So if you're in the ER, you probably are not seeing the super happy diabetics, and you're working in medicine or in GP, hopefully you're seeing more happy diabetics. So your happy diabetics, all of their symptoms are due to the amount of sugar that they are basically peeing out and losing in their body. So they're going to be polyuric or polydipsic. They're peeing a lot. And that is because the kidney has to work harder because of the glucose in the urine. And we're losing more urine. Every time that sugar goes through the kidney, it's going to pull more water through the kidney. So to compensate for that, we're going to drink more. And that's usually one of the first things that owners will notice. They're polyphagic, so they're hungry. And again, like we said, this is a disease of starvation. So they need to eat more because they're not able to utilize that glucose, and yet they're eating a lot and they may be losing weight. The other thing that a lot of dog owners will report is that they may get cataracts. Sometimes that is even their actual first presenting complaint, is that the owner notices that their eyes are cloudy or that their dog has gone blind. And in cats, particularly cats that have been diabetic for a little while and maybe are not very well managed, they will get this like plantigrade stance, which is a component of diabetic polyneuropathy. We don't 100% know how or why that happens, but we think that the high glucose kind of starts to kill the nerves off over time. So this is what those cats will look like. They'll be down on their hind limbs. And they may be a little bit weak in their back end back there too. So then we have the unhappy diabetics. And unfortunately, any happy diabetic can become an unhappy diabetic. That is when we get worried about one or two of the major complications of diabetes, which is either diabetic ketoacidosis, so we're not controlling their diabetes well enough, and they are persistently or transiently hyperglycemic, or we are overshooting a little bit with our insulin and we're becoming hypoglycemic. So unfortunately, you'll see here on my list of symptoms, they actually can present very similarly. So you can have an animal in DKA and they're weak and they're lethargic and they're not eating great, or you can have a dog or a cat that has low blood sugar and they're weak and they're tremoring. They may be having seizures or other neurologic signs. So we want to look into this a little bit further, and the best way for us to do that is to do some more blood work, which we'll get to that in just a second. So for happy diabetics, how are we going to diagnose them? We want to look for those appropriate clinical signs. We're going to check blood work, and we need to have a hyperglycemia usually of about greater than 200 milligrams per deciliter. So a little bit of hyperglycemia, especially in a stressed animal, I don't get too worried about it. If you're ever worried, you can always check a urine, and they should not have a huge amount of glucose in their urine if their blood glucose is just a smidge elevated because they're stressed. So basically, we have to make sure that if we check the urine and there's glucose in the urine, that it's not from something else. So we need both of these pieces of the puzzle together, because the high blood sugar will distinguish diabetes from other renal diseases that are going to cause you to lose glucose in your urine, which are much less common, but we still need to work them up because that's going to definitely be a different treatment plan for those dogs or cats. Usually it's dogs that are going to get Fanconi syndrome. So Fanconi syndrome is where we have a normoglycemia, meaning the blood sugar is normal, but we're losing blood sugar because of something going on, usually from the kidneys. Now, if we have glucose in our urine and we have hyperglycemia, then we have to check and make sure that that's not something else going on. And we talked a little bit about stress hyperglycemia. It happens pretty commonly in cats. We can have a stress hyperglycemia so great that they will also be glucosuric. So if you're ever worried or wondering, it's easy to just run a serum fructosamine. Most of the time, add on to the blood work that's already been done at the lab, because they don't really need that much serum to run it usually. And if it's normal, that will rule out diabetes, because that serum fructosamine, we'll get to this a little more in a bit, is going to give you a ballpark average over a couple weeks of where their blood glucose is at. So our unhappy diabetics, what are we going to do to diagnose them? So there's a couple definitions on here that we kind of throw around, but I want to make sure that everyone is kind of all on the same page with this. So if we have hyperglycemia and a glucosuria, meaning we have high blood sugar and we have glucose in the urine and we have ketones in the urine, we are in diabetic ketosis. Now that's when I start to get a little ping in my brain, like, okay, how is this pet doing? Am I worried about this pet being in DKA? Is it acting sick? And the next step we want to do to investigate that a little bit further is we need to check the blood pH. So if we have a hyperglycemia and a glucosuria and urine ketones and acidosis, which we're going to get from our blood pH levels, which usually here at OVRS and pretty much anywhere you're going to go, we're going to measure on a patient side venous blood gas, or here we call it our EPOC. So that would be called a DKA. We will sometimes, as kind of a joking way, and it is kind of helpful, call these guys DK no A. And it does matter a little bit in terms of prognosis because, and I'm sure you guys on ER and critical care can speak to this a little bit more. Generally speaking, the DKAs are a little bit sicker because of that acidosis. They usually, at least when I was hospitalizing them a lot, I used to tell people that they may need a little bit longer of a hospitalization time because we're going to have to give these guys fluids and get them feeling better before we're going to get that blood pH back to normal. Now, the flip side of things, and remember, we said that our unhappy diabetics can present in kind of very similar looking ways. Our hypoglycemic animals, they're going to be lethargic, they're going to be weak, they may not be eating. Anytime we have a pet that is presenting for seizures, we should check a blood glucose on them, even if it's just a little spot, or we will get our blood glucose on our EPOC, because we want to make sure that we're ruling out seizures due to low blood sugar versus seizures due to like a neurologic cause. I went to the SEVMA Neuro CE last week, and the neurologist who presented was a friend of mine, and she said she's seen cases where people were giving dogs with like liver shunts or diabetes who were hypoglycemic, and that's why they were seizing, and they were giving them 2-3 different types of anti-epileptics. Well, that's not going to fix the seizures, because unfortunately these patients need dextrose or need some sort of glucose supplementation. So we definitely don't want to miss that. So this is what your urine dipstick's going to look like if we have glucose, which I think most of you guys are familiar with, but I just wanted to make sure we're all on the same page here. And then same thing, what we're going to see when we see ketones here on our dipstick. And then this is what the EPOC will give us. I couldn't find a good DKA. I had to dig through my things, but this was a DK no A. So her glucose is high, but she still has, I think it says 3.3 or 7.37. So her pH is on the lower end of normal, but she's not truly acidotic yet. So when we have an unhappy diabetic, we want to make sure that we're looking for other conditions that might have been causing to them to either become diabetic or to not be, responding well to treatment. So in intact female dogs, going into diestrus can cause us to become poorly regulated. Cushing's disease is always something we worry about. Pancreatitis, I always tell people it's kind of a chicken or an egg scenario, because all that glucose makes the pancreas kind of unhappy, but yeah, pancreatitis can also make us become insulin resistant. Obesity is a huge one, especially in cats. Acromegaly, which you guys may not be super familiar with, there are actually a couple of really good papers coming out in JFMS that were really underdiagnosing acromegaly in cats. And what that is it's a pituitary tumor. So they're producing excess growth hormone, or giantism is another word for it. And all that extra growth hormone is going to make these cats insulin resistant, and then they are diabetic. Obviously, any exogenous steroid use, we talked about that too. And then the other thing we want to make sure we look for are other diseases that are going to happen because you're a diabetic. So we want to make sure we are checking for UTIs. There's a little bit of debate about, in the happy diabetics, how often are we screening these guys for a UTI? I generally don't necessarily look too hard for a UTI. Now, if they're having symptoms of a UTI, we're going to want to work that up. But every unhappy diabetic should have a urine culture done, because a bad UTI, or even a bad UTI that has now become a kidney infection or pyelonephritis, could be a reason why they are now an unhappy diabetic. And anytime a pet is sick, they have an increased likelihood of insulin resistance. So their body can't respond well to that insulin because they're fighting something off. And that might be why they are becoming an unhappy diabetic. Pancreatitis, same thing. We already covered that, chicken or an egg scenario. And or are they having diabetic cataracts, and has that led to a glaucoma situation? Do we need to look at their eyes a little bit more closely? All right. So say we have an animal and we diagnose it with diabetes, and they're doing pretty good. What do we need to do? And this is where I think our technical staff really is super important, because I always tell people that the diabetic appointments, the DKA discharges, the new diabetics, these appointments take a lot of time. And we really do need to take the time to sit down and explain to this owner that this is a big commitment, and that this is something that they are going to need to do diligently for the life of their pet, in order to keep their pet feeling well and to manage them as a diabetic. And someone told me it's like a new lifestyle. So this is unfortunately now not a cat that you can leave for the weekend and throw out a bowl of food and, somebody comes and checks up on them here and there. That's not going to be an option for people. Or maybe your dog went to doggy daycare, and now you have to make sure that your doggy daycare is going to be able to give that dog insulin twice a day, make sure it's eating when it's at doggy daycare. So there are all kinds of life factors that people are going to need to take into account here. I tell this story, and this is like the most heartbreaking thing. When I was an intern, I saw this dog that came in DKA, and she was owned by an elderly blind woman. And the blind woman was unable to give this dog insulin. She couldn't draw up the insulin on her own. She lived by herself. The son would come over once a week, which was like the best that everybody could do. And he would pre-fill the insulin syringes, which is not good. But she wasn't sure if she was able to get the insulin into the dog. And every time that she gave the insulin, she never knew if it was going into the dog or not. And ultimately, she made the decision to euthanize that dog because that was going to be the best course of action for that pet. So it can be really life-changing for people. We have to really take that into consideration when we're talking to people about diabetes. The other thing that happens, especially on medicine, I will see a lot of people who are kind of obsessive about managing their diabetic animal. It's the other side of the coin. And you really want to tell people we are never, ever going to get them as tightly regulated as a human would be. In humans, we have made huge advancements in the management of diabetes. Most humans with diabetes wear, glucose pumps or insulin pumps or glucose monitors, things like that. And the reason we want to make sure that we're managing humans really, really tightly is because as a human is a diabetic for longer and longer, we're going to have a higher likelihood of diabetic complications, like diabetic neuropathy, wounds, eye issues, kidney issues, things like that. So in a human, we really have to tightly regulate humans to have them have a good long-term quality of life. The other important factor is if I am a human with diabetes and I take a little bit too much insulin, I'm usually going to know, I'm going to feel kind of funny and feel a little lightheaded, and maybe I need to eat a snack or things like that. So a lot of times with humans, what they will do is give them a shorter acting insulin that they can use at meal times and things like that. And people can kind of regulate. Unfortunately, our dogs and cats can't really tell us that they're feeling most of the time they're pretty sick. So we're never going to get them as tightly regulated as a person would be. That's not our goal. But what we do want them to do is to feel good, be at a stable body weight. They're not in that starvation mode anymore. We don't have polyuria, polydipsia, polyphagia. The owner is happy, the pet is happy, life is kind of coasting along here. The other thing I always make a note of is to warn owners that your pet, even if they're well controlled, and that's a little bit of a myth, is that if they're not well controlled, they're going to get cataracts, or if they are well controlled, they're not going to get cataracts. I've seen very well controlled dogs get cataracts. I've seen really horribly controlled dogs not have cataracts. And that's devastating for some owners because they may end up having a blind pet, and that's something we do need to, educate them on. So then the patients, what do they need? Well, they need insulin. So sometimes, especially dogs, we can have the honeymoon period right after we diagnose them where they really don't need very much insulin and they will respond very, very well to just a small bit of insulin. But unfortunately, that usually doesn't last because remember, in dogs, the issue is that our beta cells in our pancreas are not working super great. So over time, unfortunately, the ones that are left are going to kind of fatigue and poop out, and we may need more insulin. Now, cats, it's the other hand. We often will want to kind of treat them pretty aggressively. I will put cats on a pretty tight regulation, pretty high level of insulin that, I feel like is appropriate for that cat, and a pretty tight diet, because we have shown that if we can tightly regulate these cats in the beginning, we have a higher incidence of them going into remission. And the other part of that is especially if we can remove the underlying cause of their insulin resistance. So can we get that cat off of steroids? Can we get, that cat feeling better? But I do always warn people that they can relapse later. I always tell people they're kind of always like a pre-diabetic cat in my book. And we do want to be monitoring them regularly for those recurrence of diabetes symptoms that would make me want to check a blood sugar, check a fructosamine, get that cat reevaluated because they might be coming out of remission. Insulin, I'm not going to spend a ton of time on this, but basically it's got different sizes. It's, made of different things made by those beta cells. And then if we have extra insulin floating around outside of the cells, it's going to be degraded by an enzyme called insulinase. So we think that insulinase may also be another way for us to treat some of these insulin resistant patients. Can we slow this destruction of the insulin down so we have a little bit more insulin floating around? So just so you know, that there's kind of some newer drugs coming out that are kind of trying to work on these different mechanisms. Dogs, we usually need an insulin that is of intermediate duration. So dogs 99% of the time are going to need insulin every single day, twice a day, ideally with an actual discrete meal. If we have dogs that are more grazers, sometimes I will kind of see what we can do and treat them almost more like a cat. I may put them on Detamir, I may put them on Glargine, a little bit of a longer acting insulin. But by and large, your average diabetic dog is going to need something like an NPH, Vetsolin, an intermediate duration insulin that's going to be given every 12 hours. And cats, remember, they're insulin resistant. So we have a harder time in cats. We usually need to use a longer acting insulin. And we may need to kind of play around with them a little bit more, in my experience, to get them really well managed. So this is just a little picture of the different types of insulin. When patients are in the hospital, especially with DKA, we will often give them regular insulin, which has a half-life of about 2 to 4 hours. And then we'll check their blood sugars kind of intermittently while they're in the hospital. And then we may transition them to a longer acting insulin like NPH or Glargine to go home with. So regular insulin, already said that. NPH, I like NPH. I think that it's usually cheaper. This is a human insulin. Some dogs, it's not long enough. In cats, it's usually never long enough. But the benefit of this one is that it is less expensive. And the nice thing too is, say somebody goes up north and they forget their insulin, I can just call this into like a Walgreens for somebody. So that's kind of a nice aspect too. Vetsolin is the only one that's labeled for diabetics. I don't really take that into account too much. I think about what is more important for my patient. I have some dogs and cats that are doing really, really well on Vetsolin. Again, some cats, it's just not long enough for them. The nice thing about Vetsolin is it's kind of a dual phase insulin. So what it does is it gives them a little boost at that initial point, and then it kind of tapers off more slowly over 12 hours. So I think it's good sometimes for dogs. It can get pretty pricey in a big dog, but it's good for dogs that are on that nice BID meal system, so that they get a little boost right when they're eating their food. And there's a picture of the dual peaks, courtesy of Zoetis, whoever makes Vetsolin. I have no financial backing on any of these. The other one is Glargine or Lantus insulin, and this is also a human insulin. It is the first choice, in my opinion, for cats. This one's also getting kind of pricey, unfortunately. The pens are usually less pricey. They just came out with a generic pen, which is actually reasonably affordable, I think. The biggest thing is that you just have to make sure you show the owner how to use the pen, and we have to get the little needles that go with the pen. Usually in an average cat, I'm going to start a unit or like 1 click per cat every 12 hours. And remember, if we go back to our picture, this is going to be kind of that long acting straight curve. So I have also used this in those little like Chihuahuas and Shih Tzus and stuff that don't really get fed on a meal basis. They kind of just graze throughout the day, because in my mind, those are cats anyways. And so I kind of treat them with a cat insulin that maybe is a little bit less kind of boom right in the beginning, more a little slow and steady throughout the day. Oh, look, I already had a picture in there. Prozinc, same thing. I'm kind of meh about Prozinc. I feel like it's not like amazingly different than Vetsolin, and they have marketed it pretty aggressively for cats. And I don't love it for cats. I'm really kind of an old school gal. I feel like most cats in my experience do a little better on glargine. But if you have a cat that is doing really good on Prozinc, I'm probably not going to rock the boat there. Again, what do they need? Insulin. They really just need insulin. So everything beyond that is kind of just working out details in terms of what works better for that patient or what works better for that owner, things like that. In dogs, I usually will start them on a pretty wimpy dose of insulin. Again, remembering we have that honeymoon period and we might need to go up. I usually won't start, especially in a big dog, my diabetics at anything greater than a half a unit per kg. And same thing for cats. We usually won't go above 1 unit total if we're talking PZI or glargine. Remember, this is not units per kg. Please don't give your cat tons and tons of insulin. So needles and syringes, this is where it gets complicated as well. And this is where we need to make sure we're really being diligent in our medical record keeping and what we are telling owners and explaining to owners, is that we need to make sure we're having the proper insulin that is going home with the pet recorded properly, that our prescriptions are recorded properly. I will usually actually write a separate prescription for my syringes so that they are in there and it is documented. Any of your U40 syringes are going to go with U40 insulin. So Vetsulin is U40. Most of your human insulins, like your Novolin, your Glargine, are all going to be U100. There's this weird thing on the internet where because the U40 syringes are more expensive, you can divide by some number and switch and whatever, and owners try to pull that crap with me. And I tell them it's very dangerous. I don't want people playing around with the numbers of the insulin. It's so easy to make a decimal error or a, 1 click, 2 click error with insulin, and we can really wind up in trouble. That also being said, double check yourself. I think we have a policy here at OERS where every insulin dosage is checked by at least 2 techs, and I think that's very, very important. I absolutely 100% have seen this happen. These are patients in the hospital. This is not an owner at home who's been giving their dog 6 units of NPH every 12 hours for 3 years now. Our routine is not their routine. Our syringes might look different. We need to make sure that we're really being conscientious about making sure that they're getting the proper dose of insulin, because it's really, really bad when that happens. So what are our goals when a pet is on insulin? Remember, we want them to be happy diabetics. So we want to control their clinical signs, we want to control the clinical signs, and we want to control their clinical signs. Most happy diabetics are going to have reasonable control of their clinical signs, and that is going to be our guide to how they are doing. Most of your unhappy diabetics, the ones that I'm always kind of worrying, are you teetering on the edge of going into DKA, are not going to have good control of their clinical signs. Now, if we're really getting picky here, we can run some glucose curves. We can do some glucose monitoring, which I'll get to in just a second here. But we want to have our glucose kind of relatively within a normal nadir here. The nadir is the lowest point, so we don't really want them going below 65 milligrams per deciliter. We really don't want them going above 300 at their highest point. Food can be really, really important. We want to have a high fiber, low fat diet, especially in cats. Like I said, we want to try to really aggressively manage those cats in the beginning because we have a higher likelihood that they may end up becoming a remission cat. There's all kinds of other drugs that are kind of coming out that I'm still not like super convinced are going to be that clinically important for us here. There's been a big push with the SGLT2 inhibitors, which is called Bexacat. And that is supposed to be used kind of in those pre-diabetic patients, but you also have to make sure that they're not insulin dependent. So it's a little bit complicated, and I don't think that most of our patients are going to be a good candidate for these, because usually by the time they're seeing us, in my opinion, they need insulin. So we talked a little bit about blood sugar curves. There's a little bit of information on there. I'm not going to spend a lot of time on that. Remember, our nadir is our lowest point of blood sugar, which is going to be our highest action of insulin. We usually don't want it less than about 60. And then do remember that your glucometers are going to have a little bit of a built-in safety feature. They're going to read about 20 units per deciliter lower. So if we're at 60, we may actually really be at like 80. but we would rather have them be running a little bit higher than running too low. So when would we curb? I'm not a huge fan of owners doing curves all day, every day on their patients at home. I think it's stressful for them. I think we have better ways of doing this. But we would curb when we are worried that the insulin's not working well, it's not working long enough, or our nadir is happening either too soon or too late, with our timing of our insulin. Or if we're really not getting control of those patients, and no matter what we do, they have a persistently high fructosamine, they don't have good resolution of their clinical signs, and whatever we're doing is just not really working. The other thing we can do is have owners do spot BGs at home. That can be hit or miss depending on how well your owner is doing with that. What we'll do a lot of times instead, if owners want to do spot BGs, is put a Freestyle Libre on these guys. It's not a blood glucose monitor. That's a misnomer. It measures interstitial glucose, so the glucose between the cells. Every 15 minutes for hopefully about 14 days. Sometimes they poop out a little bit sooner than that in our veterinary patients. It's really easy to apply. I have a video in here that I'll probably just send out. I don't think we need to spend a ton of time on that. Unfortunately, I have some patients that I really believe it's really accurate, and I have some patients that I'm like, I don't buy that this is real accurate on you. I also have some patients that it stays on and it works really, really good. And I have other patients, particularly I feel like dogs, big dogs with like real thick skin, that I just don't think they read all that well, and or I've had a few of them fall off as they've been like jumping out into the car in the parking lot, and that's always kind of a bummer. Low may be common, so you kind of always have to take low with a grain of salt. But again, remember, we're going to read a little bit falsely low because we would rather catch it before you drop too low. Again, in people, we're always worried because we're a little bit more aggressive with our insulin. We always want to make sure they're not dropping too low. But unfortunately, this can be really, really a lot for owners. And sometimes owners get really, I think, kind of obsessed with this, and they want these on like all the time so they can see what their dogs are doing all the time. And ultimately, I think that kind of takes away from, we're treating the patient, not the numbers. You don't have to drive yourself crazy. Sometimes they're not all that accurate. So if there is a concern, we really should just be getting that pet in and doing an exam, maybe checking some blood work, just making sure that pet is doing okay. That's the video on how to attach the Freestyle Libre, which you guys can all watch later. Oops. We're going to watch it later. There we go. And this is the readout that you'll get. They're actually really, really cool. You can link them with your phone and they can send stuff right to you. They can do like minute to minute, like, oh, Fluffy ate at 8 o'clock, and they'll map it out for you. So it's really pretty fancy. In the hands of the right owners, it can be a really, really powerful tool because you can really see, what they're doing day to day. I'll put these on when I'm worried, kind of like we would do a curve, when I'm worried that maybe what we're doing with our insulin isn't working quite as well. Do we need to go up on our insulin? Do we need to go a little higher in the morning and a little lower in the evening? Do we need to switch within insulin with a longer or a shorter duration of action? And this is really helpful to answer those questions. We talked a lot about fructosamine. I'm going to skip that because I want to make sure we have time for questions. And again, remember, if your patient, especially your cat, has a low normal or a normal fructosamine, that means that they're probably dipping down into the low range at some point over that 2-week period. And we would be worried about we're either overshooting with our insulin and they're becoming hypoglycemic, or they may be going into remission, which would be awesome if you were a cat with diabetes. This is like the lo-fi way to monitor at home. We used to do this a lot with people, but I think it's kind of a pain in the butt. So I don't recommend this too often, but keto diastics are super easy to use at home. They basically just run them a couple times a week, catch some pee, run it in there. Basically, we're shooting for, are we really, really high on our glucose? We should always have some glucose, and we should always have no ketones. This is the most important thing. Look, it says most important. There's a lot of, I put some resources at the end of this talk, but there's a lot of really good information on AHA's website. They have a diabetes like a consortium with guidelines and things like that. And they have a really nice owner log. They have a really nice video for owners on how to like monitor your pet's symptoms and things like that. So sometimes I will have owners do these, especially if they're owners that are not always the most like reliable in giving histories when they're coming in, or if they're owners that just can't or won't do freestyles or glucoses at home. This is a really simple, easy way, and it actually really does help us look and see at what's changing over time for those pets. So long and short of it, do a thorough workup to diagnose concurrent or underlying disease and make sure we're actually diagnosing them appropriately. We need to educate owners and meet them where they're at and realize that, you know, we're going to be able to get some animals and some owners really, really well regulated. And that may not be a reflection of the owner or the pet. Some owners and some pets, we may not be able to get them really well regulated. And then the mentor of my mentors, kind of the grandfather of veterinary internal medicine at Michigan State, always used to say each diabetic is a new experiment. And I really like that because none of these patients are exactly alike. Questions?
Hey, Katie, I have one question for you and then a couple things I wanted to add. Often in the ICU, when we admit new diabetics, DKA patients, I'm mostly starting the dogs on Vetsolin. Would you prefer that we start them on NPH?
I think it really depends. And I really think that it comes down to having a conversation with owners, because if it's going to be one of those things where the insulin cost is going to make or break whether or not they can keep coming back for follow-up, I probably would go with NPH. But if they're the type of owner that are like, you know what, money is no object, I will do whatever it takes, I would start Vetsolin. So it really does depend. I used to always say if they were big dogs, I would do NPH. If they were small dogs, I would do Vetsolin. But I think that's a little bit blurry. So it can be a little hard to choose which one you're going to start them on. And honestly, I feel like if they're not doing well on one, we can just switch them. Like, it's no big deal. So monitoring them and having them come back for their follow-ups, either with medicine or if they're doing well and their GP is comfortable, as long as somebody is managing these dogs and they're not just like going out into the wilderness.
Okay, great. Thank you. And then I just wanted to mention too, just so you know, and I know some of the staff know this, but we do have a blood ketone meter now that's like the lactate meter that you can also use to measure ketones, and it's in the lab. It uses whole blood. So if you ever want a more exact measurement than you're in ketones, we have that available. And then the last thing that I wanted to say regarding insulin dosing in the hospital is obviously, like Dr. Long said, this is an easy thing to mess up. There's multiple types of insulin syringes, there's multiple types of insulin. And so if you're ever in a situation where you accidentally give a wrong dose or use a wrong syringe, just tell us. It's something that we can fix really easily. We just need to know about it. And we've, like Dr. Long said, we've definitely had it happen before. And obviously communication is the most important thing in those situations. And if you tell us, we can deal with it. That's it.
Yes, I would concur with that wholeheartedly. I think that's like a mantra of vet med is, we're not going to be mad at you for messing up, but there will be bad things that could happen if you don't tell us what happened if you mess up. And I haven't messed up insulin, thankfully, but I've definitely messed up a few things in my time, and you just kind of have to roll with it.
Yeah, it's part of it for sure. Thank you. That was great.
And then Dr. Long, we had a question from the chat room about asking why do pets develop cataracts when they're diabetic?
Oh, that's a really good question. And the eyeball team may know this a little better than I do, but I always thought it was because the sugar kind of accumulates within the lens, and they get like lipid and they get glucose and glycogen like accumulations in their lens of their eye.
Excellent. Anybody have any other questions? Looks like the room's quiet. Well, thank you so much for your time.
Yeah, thank you guys for coming. I think this is a really
appreciate
helpful
it.
thing.
Before everybody logs off, we just want to make sure sometimes your name is on the Zoom channel. Sometimes it's not, and I can't tell who everyone is. So if you're watching the presentation and so that we can document the CE, please shoot me an email with your name or if there was, a couple people watching it from one computer or something like that, please send me the information so that I can make sure that you're that you get the proper credit for watching the webinar with Dr. Lonk. So thank you so much, Dr. Lonk, and appreciate everyone. This will be available.
Oh, like perfect timing. Eyeballs just came in to talk to us about cataracts.
Yeah.
Dr. Zimmer. Oh, I don't think, can you turn her on?
Yep.
She
She's
should be able
just-
to turn herself on, I think.
She's just
Whoa.
coming in, Dr. Zimmer.
We had a question about diabetic cataracts, and I think I answered it properly, but the question was, why do they form? We're putting her on the spot. I'll ask her later, and if I told you guys something completely wrong, I'll let everyone know.
Sounds good.
Well, have a good day, everybody. Thank you so much.
Okay.
Thanks,
Thank
Katie.
you.
Bye.
Bye.
Bonk.